Hi friends, welcome to Diagnox. This is Dr. Farakath. Today I am going to discuss the topic when not to use topical steroids. The number one abused drug in dentistry is non-steroidal anti-inflammatory drugs. I have already discussed NSAIDs in detail in my last video. If you are interested, kindly go through it in our YouTube channel Diagnox. The second most abused or overused drug in dentistry is topical steroids. The most common question asked to me about oral ulcers or topical steroids is, "Sir, I had a patient with ulcer burning sensation. I have given topical steroids. Kindly let me know what to do." And these are all few popular brands of topical steroids prescribed by dental surgeons. So, why not topical steroids all the time? Because there are certain conditions in which application of topical steroids may worsen the condition. Topical steroids may harm the patient instead of doing good. I am going to discuss few conditions in which topical steroids are contraindicated. Recurrent intraoral herpes clinically presents as multiple pinpoint ulcers that occurs in keratinized mucosa, that's gingiva and hard palate. 99% of the time, patient who visits the dental surgeon will complain of toothache. For example, the first pic you can see that the patient complained of pain in the extraction socket, whereas the second pic the patient complained of pain in the root stems 2-6. From the clinical aspects, it's very important that we diagnose these conditions first. Most beginners tend to prescribe topical steroids for intraoral herpes without thinking twice. The problem with topical steroids is delayed wound healing because of local immune suppression, and topical steroids also masks the real clinical picture, which makes further diagnosis very difficult. Oral candidiasis is another common condition which is frequently encountered in dental office, in which topical steroids are contraindicated. The first picture is a case of Stomatitis, and the second pic is a case of pseudomembranous candidiasis. We all should keep in mind that prolonged use of steroids can result in candida, and usage of steroids in an already acquired candidal infection can be destructive. The other common question in the minds of young dental surgeons is whether we should use topical steroids or systemic steroids. This is a patient with severe ulcerative and erosive lichen planus. Usage of topical steroids is not going to help this patient. Of course, we can use topical steroids as an adjuvant or as a maintenance therapy, along with primarily systemic steroids or other immunomodulating drugs. Recurrent Asda stomatitis is the most common ulcerative condition encountered in a dental office. They are well circumscribed, shallow ulcer with an erythema. Very easy to diagnose, but moving to the management, there are lots of confusion, because we often tend to ignore the cause of Asda and blindly prescribe steroids. Recurrent after stomatitis has multiple contributing factors like immune deficiency, stress, deficiency of iron, hemoglobin, vitamin deficiency, altered T lymphocytes, etc. But most of us have only one answer for recurrent after stomatitis, that's topical steroids and most commonly triamcinolone. Yes, triamcinolone aids in decreasing inflammation, pain, and it also decreases the frequency of recurrent AFT. But it's a drug most commonly misused by doctors as well as patients. When we prescribe topical steroids, it's very important that we inform the patient that this is a drug for this particular episode of AFT and you are not supposed to use this drug without my knowledge. Recently, I had a patient with recurrent AFT and when I asked her about its course, she told me that she is already using 3 different brands of triamcinolone for the past 1 year by 3 different doctors. On hematologic evaluation, the patient was anemic and without correction of anemia, the AFT is not going to resolve. So, it's very important that in case of recurrent AFT, we treat the underlying cause rather blindly prescribing topical steroids. Most often in clinical practice, when we see a patient with non-healing ulcer, we tend to take biopsy immediately. But the patient will be on topical steroids till the day before biopsy. Once we take the biopsy and get the histopathologic results, the results would be either epithelial cells found or inflammatory cells found. Then we will convince the patient to go for a second biopsy and do direct immunofluorescence. Still, we will not get conclusive results. The reason is when a patient is on topical or systemic steroids, it's very important that we stop these medications 2 weeks before biopsy to avoid conflicting histopathologic results. I would like to conclude this presentation by stating that topical steroids are double-edged sword like systemic steroids. Avoid topical steroids in recurrent herpes, oral candidiasis. Limit the use of topical steroids in recurrent AFT. Identify the cause of AFT and treat it. It's better to stop topical steroids minimum 2 weeks before biopsy to avoid conflicting histopathologic results. It's better to refer a patient to a specialist when in doubt. Thank you.